Good evening and welcome to Doctors on Call. Tonight we're talking about upper GI problems from ulcers, gallstones, and hepatitis to heartburn and indigestion. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'll be your host this evening. What would you like to know about stomach and digestion issues? We're ready to take your questions. Give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. Here to answer those questions, I'm pleased to welcome this evening's panelists. Dr. Bradley Irwin, a gastroenterologist with St. Luke's Gastroenterology Associates in Duluth. Dr. Thomas Nelson, a general surgeon with Mercy Hospital in Moose Lake. And Dr. Teresa Smith, a gastroenterologist with Essentia Health Duluth Clinic. Our medical students answering phones tonight are Chris Bullard from Winona, Minnesota, Augie Lindmark from Red Wing, Minnesota, and Kate Lopnow of Lake City, Minnesota. And now, on to tonight's program on upper GI problems. Well, Dr. Irwin, I was in the pharmacy the other day, just walking through, and there are all these medications for heartburn. I mean, omeprazole, and there's a whole bunch of them. What's with all our heartburn these days? I mean, why do we need all these medications?
Well, yeah, it's a pretty common complaint that we get. Many patients come to see us in the office with complaints of heartburn. A lot of times it's somewhat sporadic and doesn't necessarily need to be treated aggressively. And other times, persistent heartburn, we do end up treating them and end up performing procedures to assess that. So.
Is there anything in our diet or things that we're eating or drinking that are causing this?
Oh, sure. Lots of foods and beverages can lead to more heartburn. As you know, too much caffeine can lower the resting pressure, the lower esophageal sphincter, and that can create heartburn problems. Too much alcohol, tobacco, those kinds of things can certainly create more heartburn for people. And just eating spicy foods can lead to heartburn, and that's not actually an acid reflux problem, but more of a discomfort or pain caused by the foods themselves. So.
Great, well, thank you. Dr. Nelson, speaking of omeprazole as one of the medications, how should people, if they are going to take this, how should they take it?
Well, with that medication, it's called a proton pump inhibitor. It's not an antacid that you can take once you have symptoms. You should take it in advance of symptoms. And the best way it works is to take it about a half hour before you eat, because it has to be coming into the system as the acid pumps are turned on to turn it off when you eat. So you can't take it well before meals or with meals or after meals. It has to be just before to get the best outcome from that.
Great, and then if you are on these medications, I mean, they work very well, but how long should people be taking them before you get checked out?
That's a really good question. And the over-the-counter proton pump inhibitors like Prilosec and some of the others are available over-the-counter now. Usually you can buy a 2-week course of treatment. And the reason for that is that people who have symptoms that last more than a couple weeks, and particularly patients or individuals who have symptoms every day for a prolonged period of time, probably should get checked out. One of the things that concerns us in patients who have frequent, and by frequent I mean several times a week or daily acid reflux, is that they could develop something called Barrett's esophagus, and that's a change in the type of cells that line the lower esophagus. And the reason we get concerned about that is that people who have Barrett's esophagus are at somewhat increased risk of developing cancer of the lower esophagus or upper stomach. And so individuals who have frequent heartburn should probably have an endoscopy to make sure that they don't have Barrett's esophagus. And they need to review their lifestyle, their diet, those types of things, because making adjustments there can often help. There are people who need to be on proton pump inhibitors for a long period of time, some people even indefinitely. They're fairly safe medications, but our goal usually is to try and work with patients and change lifestyle things first to see if we can hopefully get them off their medications in the future.
Well, thank you. I guess on this same subject, Dr. Irwin, I have patients come in to me and they say, I've got a hiatal hernia. Now, as if, you know, we all know about hernias, but other types of hernias, but is a hiatal hernia something you have to fix, or what's that all about?
Not necessarily. Hiatal hernia essentially just means the stomach's rising above the diaphragm. The problem is that the location of the lower esophageal sphincter should be in concert with the diaphragm to provide an adequate barrier to reflux. So patients that have large hiatal hernias, even with strong acid control, can still have symptoms or perceive fluid rising up into their esophagus. And a lot of times those people do require surgery for a repair. Small hiatal hernias we see very frequently on endoscopy, and we don't necessarily recommend surgery to repair those. And oftentimes those people's symptoms can be controlled both with lifestyle modification and medications.
Dr. Nelson, I'm sure you've repaired hiatal hernias. Is that a big procedure, or is that something that's becoming more commonplace? Or
Well, nowadays we do it laparoscopically, the so-called Band-Aid surgery. And like Dr. Irwin said, hiatal hernias are very common. We see a lot on endoscopies when we look for Barrett's. And just the presence of a hernia does not indicate an operation is needed. You have to have symptoms. Usually a hiatal hernia, there's usually 5 factors that focus in right there to keep that little valve closed. But hiatal hernia kind of stretches those out in series so they can't work as well. And so you end up with reflux being the main symptom from hiatal hernias, although a lot of them are asymptomatic. And so it has to do with your severity of reflux on whether or not you have an operation to have the hiatal hernia fixed, because that's part of the operation if we would operate. Now, obstructive swallowing is another major symptom from hiatal hernias, where you eat and the hernia fills up and you can't eat anymore, and you start getting chest pressure and shortness of breath and that type of thing, and then you have to stop eating. That's indication. And then the other common one is you can get little ulcers on the inside of the hiatal hernia from it sliding up and down through the diaphragm into the chest, and people get an iron deficiency anemia, and that's indication to fix it. But if those indications aren't there, then usually just leave it alone, and you probably don't have many symptoms from it other than maybe reflux.
thank you. Dr. Smith, here's a caller from Superior who would like to know about Prilosec. If you're on Prilosec and ranitidine, can you take them without many side effects long term? I guess the question also is, are these medications, over-the-counter medications, are they pretty safe generally as far as side effects go?
They are safe. There's some concern that they might interfere with calcium absorption. So if you're taking them long term, you probably should be taking a calcium supplement along with them. There's also some concern that over the long term, and I mean several years, that they could predispose individuals to vitamin B12 deficiency. So it's not unreasonable to, if you've been on the medication for more than a couple years, to get your vitamin B12 level checked maybe every other year or something like that, just to kind of keep tabs on that. But overall, they are felt to be very safe medications. Usually if people are on a proton pump inhibitor like Prilosec, there's not much advantage to adding Zantac or what we call H2 blockers. There was some research many years ago that suggested adding an H2 blocker at bedtime gave some improvement in reflux control, but that was sort of disproved with later research. So probably not necessary to be on both.
Thank you. Dr. Irwin, a caller from Duluth wonders about what causes the coughing after eating sometimes. This person may have a hiatal hernia, they say, but it's this coughing after eating.
Yeah, I mean, I guess for me, the cough can be a lot of different things. It could be a symptom of acid reflux. I mean, it could be symptoms of other things, postnasal drip or a pulmonary issue. If somebody comes to me, I guess, and actually Dr. Nelson probably taught me this more than anybody, and they wake up coughing at nighttime when you're laying flat, that may be a better indicator that that cough is related to acid reflux than, say, coughing after eating or coughing in an upright position. You know, I tend to think more about those kinds of things. But if you eat, overeat, eat the wrong foods like we talked about, and get acid refluxing up into the esophagus, potentially that might indicate some acid reflux. Some people have a small patch in their upper esophagus that's actually ectopic gastric tissue, and there was some thought that that could potentially secrete acid too and lead to laryngeal symptoms, hoarse voice, cough, etc. But in general, you know, that's kind of how I'd leave cough with eating.
Thank you. Dr. Nelson, I used to have patients in the past, this was years ago, and then we used to have them have ulcer surgery, various ulcer surgeries. Are those still done anymore with all these new medications?
It's pretty unusual. Back when I was in training, way back when, we did a lot of gastric surgery for ulcers because back then we didn't understand the pathophysiology of ulcers, and it was caused mainly by Helicobacter pylori as a bacteria that can cause that. And once that's been identified, the incidence of peptic ulcer disease has markedly diminished. But we still have to do surgery on the stomach for ulcers occasionally, particularly for complications, bleeding, obstruction. The stomach outlet is narrowed by ulcers, and the food can't leave the stomach, so then you have to go in and fix that. So the old days of the truncal vagotomy, cutting the nerves to the stomach, taking out part of the stomach, is very unusual.
Okay, well that's good. Dr. Smith, we have a caller here from West Duluth. She had a lot of bloating at the beginning of the summer and found out that she had fructose intolerance. Do you know anything? Well, it says, do you know about fructose intolerance? Is her question. Is there some type of lactate type thing for fructose, or that's an interesting question.
It is a good question, and no, unfortunately, there isn't anything like lactate for fructose. Fructose is sugar that's common in fruits and vegetables, and your body needs to break it down into smaller sugars to absorb it. And some people are fructose intolerant, meaning that they can't eat just like some people are lactose intolerant. If they eat too much fructose or too much lactose, it overwhelms their small intestine, and those sugars get down into their colon where the bacteria break them down and produce gas, and that can cause bloating. So it's a real thing, and it's actually not all that uncommon. Usually we can treat it with diet modifications, and so if people are drinking a lot of fruit juice or a lot of regular pop that has fructose in it, just cut back on those things, and that will often take care of the bloating.
Okay, great, thank you. Dr. Irwin, a caller from Duluth wants to know about, does Prilosec increase your likelihood for C. diff infection or other infections?
Yeah, certainly there's a concern about that. If you reduce stomach acid, that's a natural barrier to enteric infections, any infection down the road. It's interesting. I guess there's two ways to look at this. There's lots and lots of prescriptions for Prilosec over the years, and you kind of have to look at the whole data, the whole picture to say, is there really a super increased risk of that? I don't think the data really bears that out. There's definitely a theoretical risk that if we're changing the milieu, if you will, that there might be some C. diff overgrowth. So I think you'll find a difference of opinion, but I don't know that I completely agree with that. So,
well, thank you. Dr. Nelson, a question regarding gallstones. Gallstones are a pretty common thing, gallbladder disease. If you have gallstones, does that mean you have to have your gallbladder out?
Not necessarily. When people come to me with gallstones, they have to tell me symptoms that I think are referable to the gallbladder. A lot of times people are found to have gallstones during the workup of kind of non-specific symptoms, and unless they're pretty classic symptoms, I would say no, they don't need their gallbladder out because they undergo the risk, the expense, the pain without much benefit, and they're still left with their symptoms. Unless they are a woman of childbearing age and are possibly going to have a child or are going to remote areas where you can't get the health care, then you would have your gallbladder out. But otherwise, you can keep your gallbladder if the gallstones aren't causing you symptoms.
Thank you. Dr. Smith, a caller from Hibbing wants to know, is a lack of appetite an important symptom for any disease?
It is an important symptom, but it's fairly nonspecific. It doesn't even necessarily indicate a gastrointestinal disease. But if someone notices a change in their appetite, that's something that they definitely should see their physician about. There are just a multitude of things that could cause that, and they would need a good history and physical with their primary care physician to kind of direct the right type of evaluation.
Sure. Very good. Yeah, that doesn't automatically mean something's with the stomach. It could be any number of
Your
things.
calcium could be too high, or there's a lot of different
Sure.
things that could cause. Yeah.
Good point. Good point. Dr. Irwin, we have a caller from Esco. What causes repetitive belching?
Oh, you get this a
my
lot.
favorite.
Yeah, exactly, exactly. The first thing I want to know, and there's lots of different questions I'll ask a patient that comes in with belching issues. Largely, it's aerophagia. It's you're swallowing air.
Mm-hmm.
And we swallow air all the time and don't even think about it. Every time you swallow saliva, you swallow air. Chewing gum, you swallow air. And oftentimes that's the main issue. There's some obvious causes too, what you're eating and drinking, carbonated beverages, overeating, excess acid, maybe not. But it's largely aerophagia is what causes belching. So I try to really narrow it down. And it's difficult for patients because they don't think about it. I don't think about it. Nobody does. But that's usually what it is.
Yeah, there's nothing inside the upper GI tract that produces gas like the colon or the large
Right.
intestine. And so I tell people, you're swallowing the air. And oftentimes they have indigestion and they get uncomfortable. Then when they belch, they feel better. And then they keep doing that subconsciously. The problem is every time they do that, they open a little valve and a little acid can come up and they can actually make their symptoms worse. So it can become a habitual problem.
Interesting. Dr. Nelson, we have a caller. This is an interesting question. A caller from Duluth would like to know, what is a flipped stomach? He had surgery for it, but it wasn't clearly explained to him.
Okay. Your stomach is usually below your diaphragm, which separates your abdominal contents from your chest contents. And it has your diaphragm is a little opening where your swallowing tube goes through. With a flipped stomach, which is what Dr. Irwin was talking about, is basically a large hiatal hernia, what we call a paraesophageal hernia. So if this is the esophagus, this is the stomach, the whole stomach goes up and then it can twist or flip.
Oh.
And in the old days when I was in training, that was a surgical emergency. We were trained to fix that right away. Now we only fix it if it's symptomatic. It's usually the little ladies that have that type of a problem.
What kind of symptoms would you get?
Problem swallowing.
Oh.
You can have pain, sometimes anemia.
Oh, interesting.
So what we do then is we go up and we just pull the stomach down gradually and we take that big hernia sac out. It's right behind the heart, and pull it down, and then we cinch up the opening a little bit and do a wrap on the stomach.
Thank you. We have a caller from Duluth wondering about hepatitis C, and is there a new treatment for that? Dr. Smith.
That's a great question. Hepatitis C, there have been tremendous changes in the therapy that's available, and yes, there are new medications. There are medications that don't require shots or interferon, which had been a mainstay of treatment for hepatitis C for 20-some years now. Just very recently, within the past year, there have been a couple new medications released, and they're wonderful. There's a wonderful advance in the treatment for hepatitis C. There are very few side effects with these new medications. Most patients are treated for 12 weeks. The chance of eradicating the hepatitis C is quite high, over 90% for most individuals. The downside is they're outrageously expensive. They're about $1,000 a pill. So there's
One pill?
one pill.
Ooh, okay. Okay.
So that's the bad news.
That's
The
expensive.
good news is they're quite effective and they're very well tolerated.
Okay, thank you. Dr. Irwin, a caller from ESCO would like to know, is there a type of acid reflux where when you wake up in the morning you have bad breath? This person doesn't have heartburn or any of the normal symptoms, but can just bad breath be a symptom of reflux?
Well, that's interesting. If somebody comes in with bad breath or halitosis, I might ask them too if they're having some trouble swallowing. They can have a small condition like a Zenker's diverticulum, which is a little pouch in the throat, basically, where food could get trapped and cause halitosis. As far as reflux is concerned, oftentimes people will talk about like a sour taste or a brash taste in the morning where they're getting reflux, and that might be a symptom too. So.
But everybody has bad breath in the morning.
True.
True enough. True enough. Now, a caller from, Dr. Nelson, a caller from Duluth wants to know about Barrett's disease. Now, I think it was mentioned already, but is that something that you need medication for? Do you need treatment for that, or is that just something you keep an eye on it?
All the above. First of all, it's a change from the normal to an abnormal lining, and like Dr. Smith says, that predisposes to cancer. It's a small risk. It's probably about 0.12% overall per year. So in 10 years, 1.2% will develop cancer. But middle-aged white guys are the ones that have the highest risk of developing that. And the longer the segment, as we call it, the length of the esophagus that starts at the junction at the stomach and the esophagus as it goes up, the longer that is, the higher the risk. And so if you're known to have Barrett's, you need to be put on a PPI or an antacid pill at least once a day. That's been shown to decrease cancer development. You need to have endoscopies on a regular basis, and that recommendation is changing as far as how frequent. It's becoming a little less frequent. To take little biopsies to see if there's any changes towards cancer. And then you need to have lifestyle changes to control reflux. And then there also are endoscopic treatments that can eradicate the Barrett's and decrease the risk of it turning into cancer. So you need to go to someone who kind of knows the whole treatment of Barrett's, and so you get the proper direction.
Thank you. I have a question here from Duluth. Does stress aggravate stomach problems or colon problems?
That's a really good question. I think in patients that have irritable bowel syndrome and some people with inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis, stress can aggravate GI symptoms. And we know that stress can, in people who have no illness, can cause GI symptoms. It can cause a loss of appetite. It can cause weight loss. Yes, depending on the level of stress, it certainly can cause gastrointestinal symptoms, not necessarily gastrointestinal disease.
Now, we used to think that, stress increases acid in the stomach, and then too much acid in the stomach causes symptoms, but that's not necessarily the case, is it?
Well, though that stress was more like physical stress, like burn patients will often develop ulcers in their stomach. So the physical stress, like if you were in a car accident, a trauma victim, yes. Emotional stress, no, probably doesn't actually increase acid production.
Dr. Irwin, a caller from Duluth would like to know if you're taking Tums for calcium supplementation for hypoparathyroidism, taking Tums, is that bad for the stomach, or is that fine? Or?
Not necessarily. I mean, it's essentially an antacid. It's very short acting. So it's going to neutralize what acid comes in contact with and be gone. So no, not necessarily. You can overdo the calcium, obviously, take too much, but in general, no, it's not going to hurt the stomach.
We have a question here regarding Celebrex medications cause bloating and gas. Any of you?
Not that I'm aware
Celebrex,
of.
is that something that's going to bother the stomach?
Well,
Could cause ulcers in the stomach. because it's a non-steroidal anti-inflammatory drug, but bloating and gas, I wouldn't think so, no.
Not as much. Okay, and Dr. Smith, finally, we just have less than a minute left. How about gluten intolerance?
Oh.
That's a big one.
We could talk for a half an hour.
So,
That's a
30
lot.
seconds, we could talk all about gluten intolerance. But no, I mean, that is something. How do you get tested for that? We'll
Well,
make it simple.
there's two things. There's celiac disease, which is sensitivity to gluten. Gluten's a protein in wheat, barley, and rye. Celiac disease can be diagnosed with a biopsy of the small intestine. But there are people who probably have gluten sensitivity. They get gas and bloating and just don't feel as good if they eat a lot of gluten. That's not the same thing as celiac disease. Unfortunately, I think it's kind of one of those fad things too that.
Okay. Well, thank you very much. I'd like to thank our panelists, Dr. Bradley Irwin, Dr. Thomas Nelson, and Dr. Teresa Smith, and our medical students, Chris Bullard, Josh Lindmark, and Kate Lopnow. Please join Dr. Ruth Wester next week for a program on lower GI problems when her panelists will be Dr. Thomas Malloy, Dr. Daniel McKee, and Dr. Thomas Oppheim. Thank you for watching, and good night.